Welcome to The Explainer. Today we are tackling one of the most critical topics for any EMT, and that is shock. Now, the textbook will tell you it's inadequate cellular perfusion. But let's be real, what it means for you on the street is that your patient is actively dying. Recognizing it and treating it fast isn't just a good idea, it's everything. So you hear all these different names, right? Cardiogenic, septic, hypovolemic, it's a lot. How do you possibly keep them all straight, especially when you're under pressure, either in an exam or on a real call? Well, it turns out there's one incredibly simple, powerful framework that explains all of it. And this is it, the perfusion triangle. Seriously, everything, and I mean every single type of shock, is just a failure of one of the sides of this triangle. If you can get this model locked in your head, you can figure out any shock scenario they throw at you. Okay, so here's our game plan. First, we're going to define this triangle of life. Then we'll break down what happens when each part fails: the pump, the tank, and the pipes. After that, we'll look at that crucial tipping point when the body goes from coping to crashing. And we'll wrap it all up with a rapid-fire review perfect for your exam prep. So let's start at the beginning and lay down our foundation. What exactly is this triangle of life, and what is perfusion? So here it is. It's pretty simple, actually. For your body's cells to get the oxygen they need to survive, you need three things to be working just right. You need a pump, which is your heart. You need enough contents in the system, which is your blood. And you need an intact container, which are all your blood vessels. Shock is what happens when the pump, the contents, or the container breaks down. All right, let's look at that first side of the triangle. What happens when the pump itself is the problem? Well, this gives us two very different kinds of shock. First up is cardiogenic shock. This is a problem with the heart muscle. The classic cause is a big heart attack that's damaged the pump. It just can't squeeze hard enough, so blood starts to back up. And where does it back up? Into the lungs. That's why your number one clue is pulmonary edema. When you listen, you'll literally hear those crackles. Now check this out. Obstructive shock is different. The heart muscle could be perfectly fine, but something is physically blocking it. Imagine fluid filling the sac around the heart and squeezing it so it can't fill. That's cardiac tamponade, or a tension pneumothorax, where air pressure in the chest is literally crushing the heart and blood vessels. You're looking for signs of that pressure backup, like JVD, those bulging neck veins. So, for your exam, here's the key takeaway. Cardiogenic is an intrinsic problem. It's the heart muscle itself. Your clue is fluid backing up into the lungs. Obstructive is an extrinsic problem. Something outside is blocking the pump. Your clue is that back pressure, like JVD. All right, let's move on to the second part of our triangle, the contents. This is probably the type of shock you think of first, but there are a few important things to remember. Hypovolemic shock is a volume problem. Hypo means low, volemic means volume. Simple, right? The tank is empty. This is your classic trauma patient who's bleeding out. But don't forget, you can lose volume in other ways. Severe vomiting and diarrhea can dehydrate someone into shock. And major burns cause you to lose a ton of plasma. Your job is simple. Stop the leak if you can and keep them warm. And now for our third side of the triangle, the container. This one is where it gets a little more interesting. What happens when the pipes, the blood vessels, get too big? We call this distributive shock, and it has a few different flavors. Let's start with a really tricky one, neurogenic shock. Imagine a serious spinal cord injury high up on the neck. It cuts the communication lines from the brain to the blood vessels. Without those signals telling them to stay tight, the vessels just go limp and dilate. Suddenly, the container is way too big for the blood inside. And here's the classic sign. Warm, dry skin, because the body has lost its ability to clamp down and pull blood to the core. Next up, anaphylaxis. This is just a massive overreaction by the body to an allergen. It's a double whammy for the container. Not only do all the vessels dilate, they also start to leak. On top of all that, the airway starts to close up. That's why you get hives and swelling, but you also hear that telltale wheezing or stridor. Your number one priority, no question, is epinephrine. And finally, there's septic shock. Here, the culprit is a widespread infection. The toxins released by the bacteria damage the vessel walls, causing them to, you guessed it, dilate and become leaky, just like an anaphylaxis. The tricky thing is, the patient might have warm skin at first, but they'll eventually become cool and clammy as things get worse. Your job is to recognize the signs of infection and give the hospital a heads up. Okay, this is a huge one for any exam. how do you tell hypovolemic and neurogenic shock apart? It's all in the skin. In hypovolemic shock, the body is fighting back. It's clamping down on those peripheral blood vessels to shunt blood to the core, which makes the skin look pale, cool, and clammy. But in neurogenic shock, that system is broken. The body can't compensate, so the vessels stay wide open, and the skin feels warm and dry. So how do you tell these two apart? Think about two things: speed and breathing. Anaphylaxis is like a lightning strike. It happens within minutes of being exposed to something, and it almost always involves the airway. You'll hear that wheezing. Sepsis, on the other hand, is a slow burn. It develops over hours or even days as an infection gets worse. Okay, so we've covered all the different types of shock. But here's the million-dollar question. How do you know when your patient is about to fall off a cliff? This is where understanding compensated versus decompensated shock is absolutely crucial. In the early stages, the body is an amazing fighter. The heart beats faster, the blood vessels clamp down, you breathe quicker. All of these are mechanisms to keep blood pressure up and get oxygen to your brain. Those are your early signs: anxiety, a racing pulse, that pale, cool skin. The body is compensating. Decompensation is when that fight starts to fail. And look at what the late signs are: a falling blood pressure and a change in mental status. They happen last. This right here might be the single most important thing you need to remember. Do not wait for the blood pressure to drop. A normal BP can give you a false sense of security. If you see the signs of compensated shock, your patient is anxious, tachycardic, and has pale, cool skin, you have to treat for shock right then and there. If you wait for the BP to drop, you've waited too long. Okay, let's put this all together. Time to boil it down to one high-yield slide. Get your phone out because this is the one you're going to want to screenshot for your exam prep. And there you have it, every type of shock tied directly back to which part of the triangle failed. For cardiogenic, listen for crackles. For obstructive, look for JVD. Hypovolemic, feel that classic pale, cool, clammy skin. Neurogenic is the opposite, warm and dry. Anaphylactic, you're looking for hives and listening for wheezing. And for septic, you're playing detective and looking for a source of infection. Know these signs and you'll know what to do first. And that wraps up our deep dive on shock. You know, mastering this stuff isn't just about passing a test. It's about seeing the disaster before it happens. So I'll leave you with this question. What are those quiet, early signs that will make you jump into action, even when the blood pressure on the monitor still looks perfectly fine? That's what separates a good EMT from a great one. Thanks for watching.